Welcome to the Doers Club podcast, where we share insights from people taking action to make the world a better place. Hosted by the Whole Health Lab, the goal of this podcast is to defeat inaction, procrastination, and pessimism, and create a community of doers for good. So welcome back to the second episode of the Doers Club podcast, hosted through the Whole Health Lab. I have two really exciting guests with me here today. So I have Brett Feldman and Joseph Becerra from the University of Southern California Street Medicine program. So just to start us off, I was wondering if you two could introduce yourselves, your role, and kind of, I feel like in kind of the setting that we're in these days, it's nice to hear some positive news. So any positive news that you've heard recently? So whoever wants to start.
Go ahead, Joseph, you start.
My name is Joseph Becerra. I'm a community health worker here for USC Street Medicine. Positive news. That's pretty interesting, right? Because you're right. We don't hear positive. To me, positive news is it stopped raining. Because it was going crazy these last 3-4 days. Insane.
And I'm Brett Feldman. I'm a director for Street Medicine at USC and also on the board of the International Street Medicine Institute. My role in the Institute is to provide technical assistance to our members. We have about 160 members around the world. And the positive news that I have to share is we were just in Sacramento for our Street Medicine Foundations trainings and learned of 3 new street medicine programs in the state. So now we're up to 58 programs.
Nice. We love 58. That. Yeah. So I guess the first question that I have for y'all is, what were your experiences prior to working in street medicine, and what kind of brought you to this field?
So for me, I've been doing all kinds of different stuff. Right before I was in street medicine, I was working for the juvenile justice system in the probation camps and like juvenile halls. So I was working with a lot of what they call CSEC kids, and that's like the sexually trafficked youth. And I've done many different things, like worked in methadone clinics. I've worked in needle exchanges. I've done a lot of drug and alcohol programs. So I'm pretty all around there. And what brought me to street medicine was that guy right there, over there.
I know there's a funny story with that one.
Yeah,
I don't know if you want to share it.
We ain't got time for that.
Okay.
I mean, I was working in juvenile justice. I was already working for USC. I was doing research projects with intravenous drug users, and I worked for Dr. Bluthenall, which is Ricky Bluthenall for USC. I think he's the assistant dean for social justice at USC. He told me to take Brett and Corinne out. There were just a couple coming from back east. I told me just be myself, just, do what I do. And so took Brett out, and yeah, he was just like, hey, you ever thought about doing this for a living? And I'm like, what, drive you guys around daily? And he went through a spiel of what they were doing and how they're going to do it and come along. And we played tug of war for a while. And finally I said, let's do it. And it was the best decision I ever did. Really is. I mean, I love street medicine.
Yeah, because when you're starting a street medicine program, you need a street guide. I was from Pennsylvania. What do I know about LA? And so, we actually had started seeing some patients. We had a consult service. So you'd go into LAC USC, that's what it was called at the time, now LA General, see them in the hospital and follow them out on the street. And, we found a few people, but mostly didn't find people. And then, but you need a street guide. So Joseph was a perfect street guide. And then, so we found about 20-25% of people coming out of the hospital, because it's difficult, you don't meet them where they are, you meet them in the hospital and you have to find them. And then right after Joseph started, it went up to 75%, like right away. So yeah, every street medicine program needs a street guide.
Yeah. And then what were your experiences prior to getting started in street medicine, Brett?
Well, I started in 2007, and things were different at that time. Street medicine, obviously existed, but it wasn't nearly as well known as it is now. And we had a shelter-based clinic in Pennsylvania. And basically, there was one gentleman who we all love. He had a intellectual disability. He was in his 40s, um, and ended up it was a rescue mission, and he ended up getting kicked out in January winter in Pennsylvania because they found a pornographic magazine in his locker, which wasn't allowed. And we were also worried about him because we had been caring for him for a few years at that point. And I went looking for him because we were afraid he wouldn't know how to survive and would freeze to death. And found him not far from the mission under a bridge. I remember coming down into the bridge, and I look under and I see him. And he's like, "Hey, Brett!" And I was like, "Oh my gosh!" I couldn't believe he was okay. He was sitting around a fire with all his new friends, well dressed, well fed, well taken care of. And even though at that point we had two clinics in shelters, and one was like a block away, I didn't know any of those guys. And so I just kept visiting him under the bridge. I got to know those folks. And at the time, I didn't know there was anything called street medicine. My employer didn't know. My malpractice carrier didn't know. I eventually told them, and it turned out okay. But that's sort of that's how it got started. Later, I learned that what I was doing was called street medicine, and wanted to do that better.
Yeah. This is great because you both kind of started answering what I wanted to get at. And my next question, which is kind of how USC Street Medicine started, and kind of alluded to how there was this consult service at the General Hospital, which is one of the big safety net hospitals in LA County. And it kind of grew out from there with this goal of bringing care to the people, if I understand correctly. So can you tell me a little bit more about that in terms of, what really made street medicine possible at USC, and what were the major roadblocks? I know that there were changes in terms of, something about like a contract that ended with county and kind of moving more so being associated with USC. So if you could tell me a little more.
Well, it was always with USC. So how it got started was, working in Pennsylvania. And there was, at the time at USC, the provost came out with these 6 wicked problems. And they were wicked in that they were bad, but also like really complicated and complex. And homelessness was one of those. So it was a homelessness initiative. And the challenge was to all the schools that, there's all this brilliance in USC. And if we all, from whatever sector we were in, committed to solving this problem, we could do it together. And so every school had to think of what would be their kind of offering to that. And so I initially came out as a consultant from the Institute. USC and a few other organizations brought me out to see, because LA, there really wasn't a lot of street medicine. There was one organization at the time doing street medicine in Venice, Venice Family Clinic. And we wanted to see if it would work in a place like this. And so came up with what I thought might work. I said, I don't know if it's going to work. And USC said, this looks great. We think you should do it. And they wanted to take the lead of all the organizations, and they recruited Corinne and I out here, which was really revolutionary because nobody had ever been recruited to start street medicine. Street medicine is traditionally like grassroots, Robin Hood, anti-establishment, and you got to convince the man that this is worth it. And USC did not need that. They were, committed to the cause from the beginning.
And Joseph, I know that you've been with street medicine as well for, pretty close to its inception. So from your perspective as like a CHW, and also having kind of lived experience with being unhoused, kind of what is your take on, what were the real roadblocks for getting street medicine started at USC?
I mean, I wouldn't know like, the ABCs of what's going on behind the scenes, but I know when I got here, we really didn't know what we were doing. It was just like, go out there and get some patients, go to the hospital, find patients. So it was just like, wow, myself and the nurse at the time looked at each other like, I guess this is what we're doing. So it was the more of the roadblocks, I think, was just maybe all the other organizations that trying to intertwine and trying to, I guess, manage like who's seeing them and what's going on with them. And, most of them are in the streets. How do you get them housed? How do you get them, just everything because it's so brand new. We don't even know what we're doing at the time. So it was just more trying to understand what we're supposed to do and how we're going to do it. I mean, it was just basically just getting it done and trying new ways of, I mean, the whole thing was new, right? Just trying new ways of doing everything.
Mm.
And I mean, sitting back now, it's just, I'm really so amazed, within the last 2 years, we went from one vehicle, maybe two, we got two in 2 years, but from like the last 2.5 years, we went from two vehicles. Now we have 14 vehicles. So, I mean, I guess what we did is working, right? Because went from four employees to now dang near 50. And we just had another guy start today, one start last week. So it's just moving, we're just going.
Yeah, that's been a huge growth at USC, and I definitely I felt that when I was on rotation with you all that there's talks of how I'd ask people like, oh, how long have you been with the program? It's like, oh, I've been here for a year, but it feels like actually people are extremely cohesive. Like it feels like they've been here for like 5 years or more. So what do you think really facilitated that growth? It's kind of is like you're building the plane as you're flying it. And I know that there's some aspects of like billing changes that have been really huge for street medicine recently, but what's your perspective on like why you're able to grow so quickly?
Yeah, the billing changes haven't even really hit yet,
Yeah.
to be honest. Um, so initially, the growth was, well, there was Measure H, which was a 0.25% sales tax that was voted on by the people of LA, which allowed a few other organizations to get started in street medicine. And then once they were out there, like us, they fell in love with the work. And we all became friends and we started growing our programs together and learning from each other. And, homelessness, everybody knows there was a big homeless crisis in LA. So it became a big political issue. And when it becomes a big political issue, usually some funding might follow that. So I would say, we were the second street medicine program in LA. Before the funding came, I think there was 6. So it did grow, maybe 6 or 7. And then DHCS, Department of Healthcare Services, so it's the state of California Healthcare Services, wanted to support the work. And they saw that people experiencing unsheltered homelessness couldn't access healthcare in traditional settings, and that street medicine was a best practice, but wasn't part of the mainstream healthcare system. So they really wanted to bring it into the mainstream and supported it with basically some funding to help build capacity. And then in LA, we went from 6 or 7 programs to 14 programs in like a year and a half. Statewide, when we moved here, we were the 6th program in the state. Last March, we published our California Street Medicine Landscape Analysis. There was 26, now 58. So that little infusion of some capacity building money allowed it to double, and that's not the billing stuff hasn't even really hit yet.
How much of that DHC push do you think was because of how big of a political issue homelessness has become versus USC Street Med or other programs kind of bringing their data? Or, what do you think kind of influenced that increase in funding?
I mean, it's all of the above. Everybody has contributed in their own way, and we also can't underestimate, I mean, truly how wonderful DHCS has been in this process. I mean, it's not everywhere that you go that the people that we serve are seen as being worthy of care. It can appear cheaper to let them die on the streets. Um, of course, we know that cost very well. That's really the cost of civilization if we just make that decision that it's okay that they die on the streets. But so we can't discount, their commitment to everybody in California, not just making you know a system that will serve the majority. They wanted to make sure it could serve everybody.
Related to that, on the topic of policy, I know that there's been recent legislation that's been passed in California, and there's been a big component of advocacy from USC Street Medicine. So, can you tell me a little bit more about how that process was? What was the goal of that advocacy, and how did you kind of build enough traction along with other stakeholders to kind of push this legislation through?
Actually, our legislation got vetoed. So,
Oh, God.
yeah,
When was that?
it got vetoed. It was I don't know, maybe 2 years ago. But
Oh,
yeah,
my goodness.
so there was the Street Medicine Act. It got through the Assembly, the Senate, and then on the governor's desk. And DHCS actually came out against it. And the governor said, the street medicine folks, they have some good points. You guys need to work together to make this work. And so that was the beginning of our relationship with DHCS. And it was, a little bit disappointing when it got vetoed because we had sponsored the bill. But I'm glad it got vetoed because if it would have passed, I don't think we'd be friends with DHCS. It gave us a chance to work together, get to know each other and each other's perspectives, and things have progressed more than it would have if the bill would have passed. So it's a good lesson in advocacy that one thing I've learned is that sometimes, folks demonize the system, and then I met the system, and they're actually nice people. And it's not that the system is always working well. For the people we serve, it was working horribly, but they just didn't know because nobody had really told them about it the way that we were able to. Because we spent time with the people, we witnessed what it was doing to them on the street. And to their credit, they were willing to listen.
Interesting.
But it's because of people like Joseph, though, that helps us really communicate that. And one thing I'd like, can I ask a question?
Me or?
No.
Yes, go.
Can I ask
Oh,
Joseph?
yeah, go ahead.
So, Joseph worked in, the helping people industry, spent time on the streets. So he knew the streets, knew, social services. I'm interested, how he thinks street medicine is different from all of those things and how it may have changed his perspective, both of his experience on the street and his experience in, other organizations.
Well, like you always say, and I've heard this from you, is we hire the heart and train the brain, right? I love that saying because in street medicine, it's the heart, 100%. You gotta have the heart to even do this for people and to go into places that we go and see the things that we see and smell the things that we smell and just where we're at. You're witness because you've been out there with us. I think street medicine in a whole is really the best solution for people that are on the streets, because the longer you're on the streets, the more you tend to just break down physically, mentally, just all the way around. Just look at like I was saying earlier, the rain. Look at being in the rain. Think about the homeless people in the rain. It was raining, pouring last night. Where were they? You know what I mean? Regardless, they're still, a lot of people always say to us, like, oh, it's raining, so you guys ain't going out today? Why? The homeless people aren't homeless on the rain? There's still homeless people out there. We don't shut down. During COVID, we were the only team out there during COVID. The whole COVID, it was like a ghost town. You wouldn't see the other organizations out there trying to help, giving those lunches, going out there and outreaching. Nobody wanted to be out there because just because there was a pandemic, they forgot humans were on the street. They're still human. no matter where they're at, they're still human. And what I've seen street medicine do is just treat humans as human, treat them as people and not treat them as, people that are full of feces, full of urine, that already have so much trauma from going to hospitals, clinics, anywhere that they go. People are already looking at them like they're some type of, they got something themselves that people are going to catch. And it's not true. So again, to me, the biggest thing that I've seen with street medicine is we just humanize people, no matter what they look like, no matter how they are, no matter what they act like, and no matter where they're at.
I really love that saying, hire the heart and train the brain. And I know also when I was on rotation with you, Joseph, that you told me that people overcomplicate street medicine. And like the most important thing is really just treating humans like humans. So I love that. And I also think it's a great transition to kind of the next topic that I wanted to talk about with you all, which is charity versus solidarity. And one of the things that I really want to get at with this podcast is asking some of the tougher questions about implementation when it comes to wanting to do good things, but then not always succeeding. So a lot of people, I think, especially, people who are, med students in my class, like kind of in my generation, are very interested in this kind of work. And I feel that people they often come with good intentions, but that doesn't always lead to good outcomes. So I wanted to hear from both of you if you can share any examples where you feel like good intentions have really fallen short or led to unintended consequences in street medicine.
One thing I always tell our teams is never to make promises. Do not promise anything, because, them, the people out on the street have been so traumatized by different organizations coming in and saying they're going to do this, they're going to do that, we're going to get you guys housed, we're going to, get you guys going, and then they don't see them again. So when we come in, it's like, oh, you guys are so-and-so. Now people really know who we are. Before it was just like, oh, you guys are them. And I would be like, no, we're not them. We're USC, we're street medicine. Well, you guys promised to do this for us. No, we never did. We're 100% medical. And all I promise you is we're going to try to help you as much as we can. So I think what happens is a lot of the people out there, their intentions might be good at first, but then after a while, they don't have no, I guess what it is they see too much and can't maybe cope with it and just continue to break promises and continue not to just be consistent. Consistency is something that we really preach here at Street Medicine, because the more we go, the more they see and the more they understand how much we care. I mean, it's just amazing. There's a saying that says nobody cares about how much you know until they know about how much you care. That's 100% street medicine. 100%.
Yeah, for me though, charity, solidarity, differences, and how charity typically comes into it. Almost all of our programs have started and been maintained on some sort of charity, mostly on charity. So I'm not putting down charity, but what happens is, as a result of an oppressive system, you get people who are in poverty and destitution, which is, poverty plus social isolation. And then there are people who, maybe have benefited in some way from that system that have extra money. And then they get to decide how to disperse it and who gets it. There's nothing inherently wrong in that for the person giving it, not for the philanthropist. What's wrong is that for the system to rely on that, to maintain an oppressive system while relying on people who may have benefited in some way from it, giving back to it. And so that's why a lot of the charity models, you end up with that it does help people, but it does not change an oppressive system. That remains intact. And so usually how that looks in street medicine is, you have your clinics, and then you have people that can't make it to the clinics, and then they come up, and then some, you know, uh, philanthropist who's amazing for doing what they're doing gives money for a pilot or something, or they get a grant for a pilot, and then they start with some services on the street, but it's not everything on the street. They might help some people, but the reality is it's not equitable in that people that need more get more, and people who need less get less. So instead of bringing everything wonderful from the clinic out to the street, because that's where the people need it, they just bring a little bit from that pilot. It's not a full commitment to change. Versus solidarity that says you have to get into the hole with the person. You need to share in some of their suffering in order for it to be effective, and bring everything from the clinic onto the street if you really want them to get it. It means really addressing the systemic challenges that caused the oppression in the first place.
Yeah. I guess on the topic of systemic issues, obviously access to housing is a huge player in our patients' health in street medicine. And I was wondering if there's any, whether good or bad, like kind of partnerships to address this systemic issue of housing between USC Street Medicine and housing agencies. I know LASA is a big player and they kind of contract to multiple smaller agencies. What are the partnerships that you feel have succeeded or failed, and kind of where do you think the lessons are from there?
You can go first, Joseph.
This is such a loaded question, though.
But we just sat in a meeting last week and we said, who are the good partners in each for each of our teams? And we had partners from every location.
I mean, I guess in every organization you get the good and the bad, the ones that really want to help and the ones that are just there sometimes to work. Um, we've, I guess we hold too many people accountable. I don't know if that makes sense. We really push other organizations, and I don't mean by push like, rudely or anything like that, but we really expect them, I don't know, to be like us and really deliver what they promise or what they tell people they're going to do. So a lot of times, I mean, we ruffle a lot of feathers, and we're doing it because we care and we want the services that people deserve. And yeah, there's so many out there. It's hard to house everybody. And sometimes there's just no place to put people. But I think a problem with some of the Lasas and the other people, like I was saying earlier, sometimes they make promises they don't keep. And when they make promises they don't keep it, now it actually kind of makes it harder for us too, because now they're like, well, you guys said you were going to house us. That wasn't us. Yeah, but you guys are with them. No, we're not. So sometimes it does put a black eye on us, but again, we're so consistent with as much as we do. And then we got like so many different, we got the social works, we got the ECMs, we got, all the new components that are helping come alongside and almost be like a whole for the program. And it's helping our patients a lot more, I think. And we just try to stay consistent. I mean, I don't know if that's an answer, but
No, it's a great answer.
Yeah, I mean, it's a very difficult thing, right? Because everybody knows there's not enough housing, and so in the setting where there's not enough housing, the way that partnerships work the best is that when you partner street medicine with the housing agencies, I feel badly for like how like outreach workers and the housing specialists have to work, because they work like crazy to get them all document ready. They got their ID, they got their birth certificate, whatever it is that they need. They get their housing application in, and then they have to wait. And they have to wait for a long time. This could be 5 months, 6 months wait. And so what are they going to do in those months? They're going to go see other people and try to help other people. And then in those 5 or 6 months, the patients they're moving around town, they're getting pushed around town. and now they've lost them. And the voucher comes through. We meet people. They have a voucher. They don't know they have a voucher. Their voucher has expired. All because of the length of time that it took. It's not always the outreach workers' fault. They just didn't know what to do for 5 months, so they went to help somebody else. And so when you partner with street medicine, we can keep them engaged. We have reason to come back within those 5 months. And when that voucher does come through, one, we know where they are and can get them, back to the housing agency to help fulfill that voucher. And they're much more likely to succeed in housing. Their, physical health, mental health is taken care of. Maybe they're using less drugs than they were before. More likely to be organized enough to get into housing and to tolerate housing and to be tolerated by the housing agency. And it just works out better for everybody. So that's when it works well, that's what it looks like.
Okay. I'm curious what it looks like when it doesn't work well, but I guess I won't press you for that at this time.
You'll get the more politically correct answers from Brett.
Yeah, I'm hearing a lot about the consistency and how that really makes a difference for patients, both not only on the medical side, but on actual housing side as well. And that's definitely something that I saw when I was with you all on rotation. I feel like another thing I noticed that really helped with credibility and just like in all of the aspects of USC Street Medicine is having such great representation of people who have lived experience with homelessness. And I remember in particular having, a patient that we saw and, I won't name names, but someone told me like, hey, that girl went to the same high school that I did. Like, I know exactly what it was like for her, I'm from the same community as her. And so obviously, having Joseph, I think, was, a huge boon in terms of recruiting other CHWs. I know that a lot of the CHWs are people who you know personally as well. But what do you think has helped you to recruit a more representative group of staff and retain them?
Recruiting is hard. It really is because, lived experience is a word that we like using, but it's not just being homeless. It's just, going through so many different other things that people go through. When I remember when I first started, I used to run into a lot of people that I knew. I mean, I still do run into a lot of people that I know on the streets. I was working in the juvenile justice. I would see a lot of the kids that I was working with, they, age out of the system and go into the streets. That's pretty sad to see. It's it's finding the right people. Sometimes, I mean, we have a lot of people that have been in drugs, homeless, and gangs, and but it doesn't mean that because you were in drug, homeless, and gangs that you've had enough time to really ready for the stuff that we do, the stuff that we see, the sometimes the working in drug and alcohol programs. I've actually had friends that were in the drug and alcohol programs, the counselors, and something would happen. They would go back to drugs. So a lot of times you just got to find the right people ready and willing to basically, try to give it their all and not go back, hopefully, and not let something trigger them and not, you know, um, the things in the past come back and creep up. So I mean, it's been a battle, but we've been pretty lucky to get some really good guys, and we're still looking. We like I said, we had one start today. You haven't met that one, but he started today, and we're still growing, and we just got to keep pounding the ground and getting the right people because the right people will make this program continue to go the right way.
Yeah, the only thing I'll add to that, that makes it hard to recruit is that people with lived experience, maybe maybe the justice involved, maybe they're in recovery too, and they're not thinking, and they've been told a million times, with that charge on your history, you're never going to work at a place like this, and so they're not necessarily thinking, boy, I could work at USC, in healthcare and be a community health worker. That's not on the radar. And so they're not looking at the job board. They're not like, oh, well, who knew USC was looking for somebody who was on the street, formerly incarcerated and in recovery. They're not, that's not top of mind. And so part of what we have to do is let them know, like, that's exactly what we're looking for these positions. So it does, as Joseph said, take, pounding the pavement, let them know, like, yes, we want you on our team. We need you on our team.
So do you do that just like on a job board, or do you like try to actively recruit in person? I'm just curious, like, what that actually looks like.
Yeah.
It's like, again, it's a work in process. I think we're trying to do whatever we can right now to get more people involved. I mean, job board, it's at USC, but again, like Brett was saying, that a lot of times I remember how I don't remember countless jobs that wouldn't hire me because of my past record. And yeah, I mean, nobody really goes like that has some type of criminal background to go on the city website or, the county website or USC website. So, I mean, we're trying to find other avenues and ways too that will help us recruit people.
And
Yeah. I can't say we
sorry,
have
go
that
ahead.
all figured out.
Yeah, we don't have it figured out yet.
Yeah.
Okay. And one thing that I don't mean to put you on the spot, Joseph, but like I remember this being alluded to when I was on rotation as like a cultural change that's happened in street medicine as you've grown. And one thing that I know is that when you bring more diversity into the team, it can bring a lot of pauses, but also brings cultural differences, which can lead to challenges. So I was curious if like either of you have experienced any challenges with this at the program and how you've handled it or try to prevent it.
I just think one thing I think we do positive, as you've been here also for it, is we meet in the morning, we go through announcements, we give daily of what's happening and what to expect, and then we break off on our teams. And I think, and just in anywhere, right? The more people you get, the more, the more emotions and everything that's going around. And sometimes you can't please everybody. But, coming into a place like Street Medicine where people are actively moving, going, caring, loving, very empathetic, we're hoping that everybody catches that and that we have no type of, things that go on. But, all we can do is try to prevent it. You really can't stop most of that because as you grow, just people come in and sometimes somebody just doesn't agree with stuff. So, it gets hard, but we try to let everybody know that we're here. Anybody needs to talk, we're available. And that's one thing about street medicine. How many places can you just walk up to your directors and just say, hey, can we talk? They're like, yeah, come on in. It's not many places. And, we're pretty blessed to be able to do that.
Yeah. I think you hit it right on the head is diversity brings a lot of beautiful things. A lot of things that workplaces have needed a long time. And in a lot of ways, street medicine is like exactly the way it should be. It's diversity in every sense of the word. I don't know how many organizations have people with doctorates working next to people with lived experience on an equal ground. And in some situations, the person with lived experience is leading the doctors. And, many different races, ethnicities, gender identities, all kinds of stuff are represented within our team. And there's lots of beauty that comes with that. Sometimes you have to work some things out. And as long as there's people and those people are human, then there's, it's never going to be perfect 100% of the time. But we always seem to come out better after something happens than we were before. Like a refining fire. So, I'm sure things will happen again and we'll address it as we can. But the important thing is that when we go out onto the street, whatever our personal differences might be, need to be left at the office. So they have enough, hard things to experience on the street, and they'll know if we're not getting along. And so I want our visit to be like the best thing that happened to them all day. It's like wow, here comes USC Street Medicine, and we see them like, oh my gosh, Joseph, I was waiting to see you. I've been looking all over for you. So we can't lose that. That's what makes it successful. It's not my blood pressure bag.
Right. Yeah.
So what I'm hearing is a lot of basically culture around like empathy, compassion, and also just open communication and more of like a horizontal type of like hierarchy versus like more vertical one. I guess just switching gears a little bit, I think one of the big strengths of USC Street Medicine program is also the ECM program, the Enhanced Case Management, if I'm saying it correctly.
Close. Care management.
Care management.
Close enough.
Yeah. And I know, like, compared to what I've noticed on my like clinical rotations before this, is that we spend way more time on care coordination at Street Medicine. I really see people constantly going the extra mile to make sure someone gets their medications or they make it to an appointment or even getting them like a nutritional shake, that they really want. And so I was wondering if either of you would be open to sharing stories of you feel the difference that ECM makes for these patients.
I mean, the reason why it seems like there's so much more compared to the clinic is because there is. And, they don't have the personal resources or the like community and family resources that others have. So, for example, if they go to an office appointment and their provider gives them a medication, an x-ray, and lab work, which is, typical, that's likely to happen. They go, they do those things on their own, they call, they make an appointment to come back. In street medicine, we have to figure out how to get them the med, how to get them the labs, how to get them to the x-ray, and then how to follow up with them. Like the burden rightfully shifts to us. And so that's what ECM does. But it also does more than that. I mean, one of our patients was dying of cancer and didn't have any family and was very lonely in some of the facilities that he had been placed in while he was undergoing treatment. And, the ECM worker, Sai, that was working with him, stopped by to see him a few times a week. And that just accompaniment and friendship that he was able to give him before he did die is, that's the world that we could do that. And so without ECM, we wouldn't have been able to give him that much time.
Yeah, I think the ECM component has helped a lot because it's probably a little bit more personal because they have a little bit more time per patient or the patients that they have more than, most people are there on the streets because not only do they get to sit with them and plan with them and, go over what they need, but they also get to, accompany them to appointments and spend a little bit more time than most of our teams because, a lot of times we're out on the streets, we're helping, and then we're leaving because we got to get on to the next patient. So I think what it does is it gives the patients a little bit more to not only expect, but also to, I guess that can't wait. Oh, I can't wait till I get to see so and so because I know that they're really going to spend time with me trying to do something other than, just the medical and leave. I mean, but yeah, I just think it's a little bit more intimate.
Mm-hmm. Yeah. I wish that we could do a little bit more of that personal relationship in other aspects of medicine. So I want to shift now to kind of looking at the future of street medicine from both your perspectives. One of the things that we've talked about when I was on rounds with you, Brett, is the major barrier to care in street medicine right now being a lack of direct access. And so, just to explain a little bit for viewers, is direct access in healthcare meaning the ability to obtain needed services without requiring a referral. So, I know that there have been patients where, for example, they see a street medicine provider regularly, but they technically have a PCP who is clinic based, who they're not super familiar with, but they need to get an appointment with them. And through that PCP appointment, need to get a referral to, let's say, get a neurology appointment to get a workup because they're having these very concerning symptoms. And often that can cause a delay of months, if not a year. And I don't know exactly what the longest time it's been delayed is, but it's
It's been
quite
delayed to
significant.
eternity. Is
Yeah,
the longest time.
exactly. So I wanted to hear from you both in terms of, how this issue, like any specific stories you have that have really affected your patients and what steps street medicine is currently taking to address this. Because I know that it's something that you're actively working on right now.
Yeah. I mean, you did a great job explaining it.
Yeah.
The crux of it is that when you get insurance, you get assigned to a PCP, and that PCP is the gatekeeper. So, especially referrals, any diagnostics like X-rays, DME, durable medical equipment like a wheelchair, all has to go through the PCP. But they're not seeing the PCP, and the PCP doesn't come to the street. And so when we see them, the PCP primary care provider, when we come to the street, we're licensed to order all those things, but because of the bureaucracy and the commercial contracts that managed care has, we can't. And so that results in patients not getting care. And so the first, and this is something we deal with every day. And the first thing we did is we talked to DHCS, and they permitted us to be direct access providers. Right now, we're working with the health plans because they did not require it; they permitted it. Some of the health plans are trying to figure out how to do it. Some of them are like, "No, I don't want to do that." And again, the result is that patients just don't get care, and the burden to connect them to their PCP falls to street medicine, who's least likely to be able to bear that burden. So, I mean, just to give you an example, we had a patient who has a colostomy on the street and needed colostomy bags. If they don't have colostomy bags, then feces comes out of their abdomen, and could not get into the PCP. There was at least a 6-week wait. And then even after, it's like weeks to order the colostomy supplies. And then the colostomy supplies, they have to remember to order, but the patient can't continue to get there. So we have to call to remind them to order, and they don't remember. And then there's nowhere for it to get delivered to because you have to get it delivered. And so what happens is we end up buying the colostomy supplies. But that falls under a category called medically necessary services, and it's the health plan's responsibility to provide that. But these are not accessible through the health plan, and so the cost gets shifted to street medicine. And so we have to do fundraising and grants and everything to cover that cost. If we don't, the patient just has feces coming out of their abdomen.
So if anybody wants to help and give on here, hey.
Yeah, let's see. I mean, is there a donation link for street medicine? I'm not sure.
Yeah, on our website. If you
Okay.
if you just USC Street Medicine, you'll see the website.
Yeah. So I will include that in the description. Yeah. Let's
Awesome.
get patients taken care of, shall we?
Definitely. That's all we're here for.
Yeah.
While we're creating a more just system.
Yeah. Do you have any stories that you wanted to share, Joseph?
I mean, it's basically what Brett is saying. Just a lot of times, we're unable to do stuff because they're locked into a certain place. And so we're fighting trying to, get them better, medical getting their medical needs done, I guess you can say. And so a lot of times when they have specialties, they have to go to a PCP that they've never seen or never talked to. And you know how that is. You go and make an appointment. It's like 3, 4 months down the line. By then, like he was saying, like the bags, what happens for 3, 4 months if we don't buy them? You know, so there's just so many different problems because they're connected with people they've never even seen, heard, or could be very far. You know, a lot of times we've had people in downtown LA, but their their PCPs are in San Fernando. It's like, what the heck? Or in Pomona. It's like, wait, like how is that supposed to happen? And then it takes a long time for it to change, you know, to get on the phone and talk to somebody to change their insurances. And then if it's the beginning of the month, you're not going to be able to get that insurance changed till the end of the month anyway. So it's just such a game, and it does affect patient care.
Yeah. So Brett, as you were saying, you know, getting patients taken care of, you're also saying the importance of making sure the system becomes more just along the way. So what steps do you think, and this is kind of a bigger question, what steps do you think are realistic to end the housing crisis, whether it's in Los Angeles or in the US? And this is for both of you.
To end the housing crisis. Well, the first thing is that you have to believe that the people on the street are humans worthy of our love. And until you believe that, then you'll just create one program after another. And it's not going to be solved by a program. It has to be a full societal change on how we view the poor and how we view the destitute. And until we're ready to do that, it'll never be solved.
Yeah, I think the system shoots itself in the foot, basically. And I mean, when I mean the system, I mean a lot of people nowadays, you know, you see somebody on the street, you're like, oh, they're just a drug addict. You know, who cares about them? They want to be here. And a lot of times, I mean, most of the time, 100, almost 90% of the time, it's not even true, because homelessness now is set up by our own people, because the raising of rents, the raising of food, the raising of gas, the raising of everything, homelessness now, a lot of people we meet were in an apartment, in a house last week, last month, last year, 2 years ago, and they lost their job. They got hurt. They were taking care of somebody, and now all of a sudden they can't pay the rent. So they go to their car. All of a sudden their car needs maintenance. It needs tags. It gets towed away. Now they're in the street. Now they're in a tent. And, you know, drugs are used for safety and not for happiness when you're on the street. And what I mean by that is a lot of times people are using drugs to stay up in the middle of the night, because the night is when you become a victim. You know, a woman on the victim is probably almost 100%, you know, on the street a victim. Men are 70 to 80% victims. And at nighttime, when you can't see nothing in front of you, that's the worst time. So a lot of times they're using substances to stay up so they don't sleep, so they don't get robbed, they don't get raped, they don't get beat. And then it's just, you know, on and on and on. It becomes a cycle, it becomes an addiction, it becomes a problem. But I think a lot of times the system is creating these problems. And then they're trying to say, well, let's end this problem that you created. So, I mean, I don't ever see it ending, because, again, everything is going up, not down. So how are you supposed to end something when everything's going up?
Yeah.
The only thing that oh, sorry, go ahead, Brett.
No, go ahead. You go.
Oh, I was just gonna say that the only thing I wanted to add is I remember distinctly during one of our patient interviews, this lady telling me that she purposely sleeps during the day because of exactly what you're saying, Joseph, is that if you get attacked at night, this is her language, like the normies aren't up. So basically people who, from her perspective, people who are unhoused are much more likely to intervene if they were to hear, for example, someone screaming, right? Someone sounding like they're being assaulted. So by being asleep during the day when it's, you know, generally safer and there are more people around to help, that is a vital part of her safety. And just the other thing I want to add is how common it is for these patients to have their things stolen.
Oh, yeah.
Like every single patient, like, yeah, my ID card was stolen last week, or all of my belongings were stolen the other day. And, thankfully, a lot of people will bring donations and clothing and that kind of thing to try to help them. But, it's just a constant cycle. So that's the only thing I wanted to add. But yeah, go ahead, Brett.
Yeah. I mean, just to, go off that, one of the things that Ricky Blumenthal, who, Joseph mentioned earlier, that employed Joseph, tracks and asks people is like, when was the last time you were a victim of theft? How often does that happen? When was the last time you were a victim of an assault or witnessed an assault? And if you think about and how often that is for them, when was the last time I was a victim of an assault or I was a victim of theft? People, the general population needs to think back pretty far to like when that happened and probably can count the number of times they were, robbed. But not so on the street. That's just like a daily thing. So that like constant threat changes your brain chemistry and changes how you approach the world.
Yeah. Thank you, both of you. And kind of as we're closing up, one of the things that I noticed as well on rotation is there's multiple different models of street medicine that are going on in Los Angeles as well as, obviously throughout the United States. And one of the things I feel has come out of this podcast is really the emphasis and the importance of consistency from the USC team. So maybe this is a leading question, but I'll try to make it not a leading question. But what do you see as an ideal model of care for this patient population in the setting of, things are not getting cheaper, it's unfortunately likely that the number of people who are unhoused is only going to increase, at least in the near term. So what are your perspectives on that?
Go ahead, Brett.
No, you go. Go ahead.
I mean, I don't know if there's like a big answer for it, but what's the main points of that question you want?
Oh, I just would like, in terms of looking forward in the future of street medicine for, people like me, the younger generation who are hoping to get into street medicine, what is the kind of model of care that we should be advocating for or like trying to promote in this health system?
I mean, I just think, going to the people and people-centered is a good way to keep, a good way to do medicine because, I mean, most medicines tell you what to do and what you need. Because I mean, it is, you're right. You got high blood pressure, you need to take these pills, you got this, you need to do this. I mean, it's understandable. And with us, it's just, what do you need and what do you want done? And people don't understand that the healthcare system, it doesn't make sense to them to waste their time to see somebody to let them know what they want. Like, I want this. Okay, cool. We'll do that for you. We're going to suggest this and this and this, but we're ever going to do whatever you want and when you want, and we're not going to force you to do anything. But we're going to keep suggesting and keep suggesting and keep suggesting, and sooner or later, they're going to be like, "Hey, let's do that." But I just think patient-centered care is 100% the best model. Meet them where they're at.
Yeah, I think I'll add to that in that we're at a critical time in the history of street medicine. Historically, we've been this, as I mentioned before, this kind of like fringe, radical Robin Hood movement. And it's self-selected to people who just love the people so much they'd do anything to get out there onto the street. And we made a conscious decision. These are conversations that actually happened with the leaders of the movement. Should we even try to become mainstream and get and be able to build? And the risk was do we lose the values and the mission and the philosophy of the work? The result of making that decision is that we'd always be small. We'd never be able to meet the need. And so we decided to go for it, to try and, get more mainstream so we could come anywhere close to meeting the need and do our best to maintain those values and philosophy along the way. And so, we have to recognize that there's different forms of poverty that we have to address. That's the best model. So there's the material poverty for like want of a home or want of food, and we're not going to be the ones to build homes. Other people can do that, and we can help with food, but we're not going to be providing 3 meals a day on the street. And so then there's the physical poverty, the physical comorbidity, substance use disorder, psychiatric disease that, if not treated now while they're still on the street, will prevent them from ever walking over the threshold into housing or keeping that housing. And we can contribute to that. But as horrible as those things are, there's the spiritual poverty of feeling unwanted or unloved that, if not addressed, will keep them spiritually homeless even after they move into housing, and will pull them back out onto the street. And so I hope as we move forward, addressing that second and third especially, that we can't forget about the spiritual poverty that needs to be addressed through street medicine.
Thank you, both of you. So I guess this is the last question for you all. Definitely of personal interest. What advice do you both have for people who are interested in working in street medicine in the future?
Go ahead, Brett.
Oh, well, these are for like med students, PA students type of thing.
Sure, I guess it would be from the perspective of like future healthcare providers, you could say.
Okay. Future healthcare providers. First, I know you all are very excited about street medicine. When I go into a room to present a few years ago, I would say, who has heard of street medicine? Nobody raised their hand. Now everybody raised their hand. And we need all of you. First, become good at what you're going to school for. So become a good doctor, become a good PA, good nurse, whatever it is you're going to school for. Because if you're not good at your job, you're not helping the patients. So, don't get too involved with things that are extracurricular of learning how to be good at your job. Once you're good at it, then you can do some of these other things. And then also decide what kind of provider you want to be. Because the world is a nasty place. It's nasty inside the system. And it'll tell you to do all kinds of things that are terrible for patients. And so you have to be strong enough to resist that. The hidden curriculum. That's what they call it.
We spoke to first year med students yesterday, and one of the things I told them is that, you go to school for a long time, you're in debt for a long time. If you're thinking about making money and being rich, street medicine's not for you. I mean, it really isn't, right? But if you have the heart and it's something that you care about people and human being human, then this is the place for you. You'll never be let down with just one of the kids asked me, how do we measure success, right? And how you measure success in street medicine is, hey, that guy used one less balloon of heroin today. That guy drunk one less drink today.
One less FU as we walked away.
One yes FU. That you can't measure. Success is measured in what you see or how you feel. So again, like Brett said, make sure you're a good doctor, but make sure you have the heart to be on the streets. Because we see stuff that, you can't unsee sometimes.
Okay. Well, thank you both, Joseph and Brett. I really appreciated your time. I feel like I learned so much from this interview. So have a great rest of your day.
You were awesome, by the way. Thank you for coming out with us.
Yes, you were awesome.
Oh, yeah, no, of course. I enjoyed it so much. Well, have a great rest of your day, everyone. And thanks, everyone listening as well, for tuning in. And I'll catch you on the next episode. Bye.
Bye.